Right, let's get started. And I'm delighted our first presentation is from Lina Gega, who is Director of the Institute of Mental Health Research at the University of York, and Byron George, who is the Chief Executive of PCMIS. I'm hoping you're here. You are here. Oh, thank goodness for that. That would have been embarrassing, wouldn't it? Over to the both of you.
Thank you. Well, I have been up and down this podium all morning. I'm very sorry. I'm back here, overindulging. So I will be brief. I just introduce the Institute of Mental Health Research and then hand over to my colleague Byron from PCMIS. So actually I have a 2-minute video just to give you a cinematic sort of effect of the Institute at the University of York. Byron, did it work this? Yeah.
That's fine.
Skip over here. Yeah. Okay, hopefully it'll work. Maybe not.
Thank you.
Across the world, people are balancing their everyday lives with increasing pressures on their mental health. Although we're aware we all need to care for our mental health, knowing how to do this can be complex. At the University of York's new Institute of Mental Health Research, we're bringing together researchers with the knowledge, professionals with the work experience, and people from all walks of life who live with mental health challenges every day. When we talk about mental health, we mean much more than the presence of problems in a person's mind. It's more than being stressed out or feeling out of spirits. Good mental health is a cornerstone of a healthy, happy, productive society. It enables communities to live, love, and laugh together. It empowers people to be ambitious and achieve their life's goals, and it inspires inclusive, compassionate, and purposeful societies. Without it, these things can seem impossibly out of reach. But at York, we understand this. We have a long history of world-leading mental health research, which has delivered greater understanding of and support for mental health challenges. And that research enables people to live better lives every day. The new institute will bring this historic work together to create a vibrant hub for our research and draw on the expertise from across many relevant fields. It enables us to do more, expand our insights, our reach, and facilitate even more collaboration between researchers, frontline professionals, and members of the public. Mental health is now a global priority, but it's always been our priority. Now, more than ever, we'll find better ways to reduce the impact of mental health problems. And together, we can improve the lives and care of anyone who faces difficulties due to mental health.
Brilliant, right. So to give you a sense, we're here representing the University of York, and York is famous for Harry Potter. You see the shambles there, it looks a bit like Diagon Alley. There's also a European campus in Thessaloniki in Greece. There, Alexander the Great, Thessaloniki was his sister. And York's contribution to the world are 2 contributions actually, chocolate and mental health care. And the 2, surprisingly, are related, because the rich Quaker families who were really striving for public good in the 18th century made the money out of chocolate, and still York in the morning and in the evening, if you walk through the city, it smells of chocolate because it's sort of the biggest producers of Kit Kats and other trivia. So the picture at the bottom is actually the retreat, which was important historically because it was the very first psychiatric hospital where people with mental health problems were treated with compassion. They had access to green spaces, to recreative activities, to purposeful living and connection with people who matter to them. And that was at the end of the 18th century. And we know all that because also the University of York hosts the Bothwick Institute for Archives, which is an international treasure trove. It is actually, you can imagine, a climate-controlled vault at the university's library, where we hold about 150 years worth of patient case notes and artifacts from psychiatric hospitals. And if you go through the archives, and there's very little research done, surprisingly, in the archives, and actually I mention them because there are two things that really struck me when I was going through these magnificent case books with thousands and thousands of people describing not only their experiences but also their treatment at the time, spanning from late 18th century all the way to the middle of the 20th century in the introduction of the NHS. So what struck me, there are two things. One is that we can really draw a thread between ourselves, where we are now, and those in the past, and realize that we're not that different. I mean, we moved forward to 100 years later, but actually human experience to pain, to grief, it's exactly the same as it was 200 years ago. And that's reassuring. The perhaps not so reassuring thing is that there was also so many similarities between the mental health services at the time and today's mental health services. We heard in the morning about, overcrowding of hospitals and how then people have to be moved out of area. And this is exactly the same, where I had patients from London moving to York because there were not enough beds or enough services. So for some things we perhaps moved forward, for others not. But again, I will say that the reassuring thing is that some of the things that we knew at the time worked for mental health, like connecting with people and things that are important to us, purposeful activity, recreation, green spaces, were also appreciated at the time. So at the Institute of Mental Health Research, really we try to do 4 things: to improve the lives and care of anyone affected by mental health problems, prevent poor mental health, protect mental well-being, but also normalize common and expected human responses to adverse or challenging circumstances. And we're very lucky at the University of York because nearly every single department at the university, across the 3 faculties, does work which is directly applied to mental health, not only medicine and psychology, but also philosophy and creative arts, business and society, law. All these departments do very much hands-on work on mental health. And to that ecosystem, we are actually then add all the partners that many of these sectors are represented here today. So the charitable sector, public, private companies, academia, and then so I guess collectively we're much bigger than the individual parts, and this is how the Institute brings everyone together. And finally, outside the academic departments, we also have colleagues like PCMIS Health Technologies Ltd and Byron will speak about PCMIS. These are important aspects of the university that bring together this entrepreneurship, the philanthropy aspect of mental health. Now, I want to just draw your attention to 2 particular interventions for which we have at the university perhaps developed expertise, and they are important because they are currently as part of our care pathways for common mental health problems. The first intervention, behavioural activation, is in the UK recommended for depression as a first-line treatment across, from mild, moderate to severe presentations. And behavioural activation is a brief intervention that is based on the principle that doing rewarding, enjoyable, and meaningful activities can lift our mood and restore people's pleasure and interest in life, and therefore reversing depression. And we have over 40 members of staff and about 15 million in funding over many years, 19 studies where we tried to gather as much evidence as we can for behavioural activation. And the long and short is that it's effective for adults, whether it's delivered in hospitals, in the community, whether it's delivered by specialist clinicians or mental health workers, or even lay people who are trained. It is as effective as full specialist cognitive behaviour therapy, which we considered to be the sort of one of the gold standard treatments. But it is also less costly, and that is important because then we took behavioural activation and we implemented it in low and middle income countries like South Asia. So the way we can achieve that is because we can deliver it with staff who are not mental health specialists. So behavioral activation is an evidence-based treatment, and really the next step is to be able to disseminate it widely. In addition to BA, another treatment specific to children and young people is one-session treatment. Again, we did a clinical trial and we found that children and young people who had very severe and debilitating phobias, most of them complicated by other conditions like autism, anxiety. So we found that the phobia symptoms improved to a similar extent with OST, but one-session treatment was likely to save money. Again, it's the difference between delivering a full treatment in 3 hours, a single session, as opposed to, months and months, weeks or months of treatment. And the reason why I chose these two interventions is because we talk about lean and scalable mental health interventions that can be delivered anywhere in the community or health services and by a diverse workforce. For the specific phobias treatment, it was done by teachers, by mental health workers, by youth workers, charity workers. So as long as people are trained and supervised, they can deliver it safely and effectively. So I'll hand over to Byron now to tell us more about what's next for lean and scalable mental health interventions.
Thank you, Lina. So this is where PCMIS picks up. We want to continue this important journey and use our innovation, use technology as an enabler to do large-scale adoption of such evidence-based important work. Now, in terms of, just before I jump into what is lean and what is scalable, we do have 16 years of experience. We do provide a wide range of intervention around talking therapy services. 1 in 3 services use our systems. We've got regional, national, international reach, but I'm also really proud that we have been awarded a prestigious award in collaboration with primary care for our interactive work, working with healthcare services, and recognised an exemplar in mental health service delivery. So we're really proud in terms of the reach and the quality of what we're able to do. One of the questions that we've had to ask, and what part of the collaboration as well, the data that was touched on this morning and the evidence is a continual strive to, to give an insight into how we can improve people's lives. Just in terms of stats as well, and I'll come into shortly, but there's lots of challenges, there's lots of historical challenges. Typically research as well takes a really long time. Quite often to a case where it's obsolete by the time it's actually, got to the service. In terms of more recent activity as well, there's lots of really exciting pioneering work, but often it loses that momentum. And this is where PCMIS comes in, with our working very closely with our research arm and the NHS Trust and organisation charities to keep that journey going and try and digitise and be able to be this here as an enabler. There's a lot of challenges around data capture, around sort of longitudinal studies as well. There's evidence that obviously treatment dose is an important factor in terms of identifying and working to develop algorithms and develop technologies and the evidence base. In terms of the PCMIS to date, in terms of some of the success story, PCMIS is used by over 10,000 clinicians daily, but it's the repository, it's this wealth that we hold that work in collaboration. We have over 5 million patient records, 40 million patient contacts, 5 billion data items, and a 99% complete data quality. And one of the really, really important parts that it means we have a vast amount of data, probably arguably the world's largest and most complete data, mental health data set, that gives researchers a real insight into patient recovery, patient mental health, that we can work together to develop new ways of improving care. What I would like to do, it's been a long day, as Andy said as well, and a short and brief, but what I would like to do, just try and a little bit of afternoon inspiration, a couple of success stories. There's a lot of sort of rhetoric still this morning, there's not much solutions out there. We don't have the data, we don't have the evidence base, and it's hard to get out there. But we've got a couple of examples that hopefully you'll find a bit uplifting, a little bit of a takeaway of things that we have been able to use to make a difference. So the first one here is a technology called outcome feedback. We work very closely, large scale, probably seen as the world's largest outcome feedback trial to date. Literally thousands of patient data used to be able to develop leading algorithms to predict when patients are off track in their recovery. It's phenomenal in the terms of it's been able to predict when patients are off track, and it aligns very nicely to the fact that it allows clinicians to intervene and identify when patients need that support at the right time. And we sort of a proactive approach. The research shows that we can increase recovery, but also reduce deterioration by 73%. But there's also a really nice win here that there's a cost-saving benefit. In terms of the technology itself, we also worked and co-designed and co-authored packages around training. So what we understand as well, it's not just a technology thing, it's encompassing and co-design, it's working across all stakeholders to be able to embed this in a very effective way. I think there's the examples earlier with the devices from the sessions this morning that they're possibly in the cupboard. We as human species, we're quite often resistant to change as well. And from our experience, we try and work collectively to remove some of the barriers around adoption as well. So this is pretty much what a clinician will see. The technology will prompt when patients are off track in their recovery, and it allows them to use their expertise in their clinical decision making to improve patient recovery. It also helps to facilitate and improve patient interaction as well in terms of the quality of the clinical contact. But it also helps the clinician to improve the quality and effectiveness of the treatment, but also, again, as I mentioned, to intervene earlier. It's a technology that allows you to be more proactive than reactive. So it's a really nice one. In terms of cost savings, the research to date showed that we could save around about 25% of treatment. So in terms of numbers, the research said we can save around about £97 per treatment session, per episode of treatment. So if you scale that up by about 10,000 patients, an average service, and you do the math, make it easier for an afternoon. If we scale it up to £100 per session times 10,000 patients. Any guesses? £1 million. Thank you very much. But that is just an example where it has that greater impact of if you're delivering less sessions but achieving the same recovery, it can address wait times, it can improve the quality of the service, it can transform and obviously really help in terms of where the challenge around wait lists and getting the right treatment to the right patients at the right time. These are the sorts of technology that we work and aim to get out there in large scale. So to date we have releases to over 15 trusts. And, it's just one of those things that we'd like to continue doing this. So we have further funding, to help train the clinicians and therapists in terms of the best use of these sort of clinical decision-making tools. Now, the other second one, this is an example, and so I'm going back to what was touched on this morning again, of thanking the pandemic in a way. I think that without the pandemic, there was probably a lot of innovation technology that would still be in infancy. And we were working very closely with NHS England's national team to roll out a more engaging mechanism for our patient portal. So this is a graph of the uptake during the pandemic period. There's a little bit of a dip where you got the second lockdown. But we're now routinely capturing nearly 500,000 patient-reported outcome measures. That's a vast amount of data that gives even more insight for our researchers. But more importantly as well, we were finding patients, more than 80% of patients were routinely working on it. It allowed, during the lockdown, services to continue operating. They didn't have to shut down, they still continued, they still were able to deal with service access. It was a really, really good example where, again, working with services, working with the NHS national teams were able to implement something large scale and very impactful to make a difference. In terms of next steps, is these sort of ideas that we want to continue doing. There's lots of other things we've got in the pipeline around stratified care and various other things, but ultimately it's that whole journey of accelerating and using these sort of initiatives to get the research out there much quicker, still clinically effective, but ultimately use innovation, use our expertise to remove a lot of the barriers that technology has, as I mentioned previously, ended up in a cupboard. We want to make sure it's there to facilitate it and be there as an enabler. So hopefully a couple of good examples. I'm always surprised as well, just as a quick takeaway, the delegate came to this morning saying we still don't have a patient portal, but technology's out there, you know, and it can transform and really help with clinician time. Just quickly going back to the previous slide, because 80% of patients are routinely capturing this, that equates to around about 1,300 clinical hours saved every month, for example. So it's a really good narrative and compelling business case to say this technology will allow you to have more capacity in the service as well. Thank you.
Thank you very much.